Please start, sir. We are live.
A very good evening to all our distinguished delegates and today's eminent faculty, Dr. Jayapandian, sir. My name is Satish Rama Joshilkar. I am from Zydus Life Sciences. Would like to welcome you all for this scientific session called CLEARTalk. CLEARTalk is one more facet of Unite Against Dyslipidemia. And in the management of dyslipidemia, we have recent development in the field of dyslipidemia, that is bempedoic acid, and late-breaking clear outcomes trial, which was presented in ACC, American College of Cardiology 2023. So we have one of the best faculty here to talk about clear outcomes through the bempedoic acid through the lenses of clear outcomes trial. Doctor, I would like to give a small brief introduction about Sir. Sir is a consultant and interventional cardiologist and electrophysicist, Meenakshi Mission Hospital, Madurai. Sir has done MBBS from Madurai Medical College and Government Rajaj. Sir is also MD from Institute of Internal Medicine, Madras Medical College and Government General Hospital, Chennai. Sir is DNB from Institute of Cardiovascular Diseases, MMM Hospital, Chennai. Sir is PDF under Dr. Narsimhan Care Hospitals, Hyderabad. Sir has experience, vast experience. Sir has worked as senior non-PG registrar in Department of Cardiology in Christian Medical College. Sir was assistant professor in Arupad Dividu Medical College, Pondicherry. And Sir has won awards like Dr. J.C. Patel, Dr. B.C. Mehta, JAPI Award. So we have, it's an honor to have you, sir, on this evening talking about clear outcomes trial, bempedoic acid through the lenses of clear outcomes trial. I would like to hand over session to you, sir, without wasting much of time.
Thank you, Satish. Thanks for giving this opportunity. So without wasting our time, we can move for our presentation. And 1 second. I think you people can visualize.
Yes, sir.
Right?
We can see. Can you make it full screen?
Yeah, I will make it. Okay. Good evening, everybody. So today our talk about bempedoic acid, important things in the management of lipid profile. So everybody knows one of the main risk factor for coronary artery disease, even before developing and after developing, after treatment, maintenance of LDL cholesterol with the recommended level, which may useful by using statin, but somehow some patients could not be achieve the goal by we can use other molecule, which is bempedoic acid. It's act on the separate mechanism of action that will helpful for control of or achieving our target level. So each 1 millimole of reduction of LDL gives more CV benefit, especially number of years in the things with the comorbid conditions. You can see that here in trial, if with the risk and risk factor reduction of risk in it can show if it is 1, it's around 11% risk reduction. By the way, it's on the more than 6 year, the risk reduction is around 36 number. It's in number. So by risk of non-fatal myocardial infarction, coronary artery disease, death and stroke, that is called MACE, which is increasing with risk factors like LDL cholesterol and LDL cholesterol with coronary vascular disease with diabetes, and these all factors with influencing this one. So management of dyslipidemia is high on priority. That is very, very important. Everybody knows about nowadays, even third tier level practicing physicians also, they are giving more importance to achieving the LDL cholesterol level. Of these, statins are the first line therapy we know, but there is a concern. Do all statins users achieve the LDL goal levels as per guideline recommendation? Definitely no. In our practice, at least 5 to 10% of patients, even high dose of statin could not achieve the recommended level of LDL cholesterol according to the patient's risk factor. Second concern, how to achieve the LDL cholesterol target after maximally tolerated dose of statin. This is two concern in practicing people. So the concern one, how we are going to clear the two all statins users achieve the level. The lower is better for longer. That is, the relative risk reduction per 1 millimole, that is 38.7 milligram reduction of LDL cholesterol. That relative risk reduction around 23% of in odds ratio of 0.77. It's a statistically significant one. So how we are achieving from our landmark trials and drugs molecules can show this graph. We start from the fibrates, which have 9 trials, and SDG map, niacin. These and all group will benefit the reduction of triglycerides, some level of LDL cholesterol. Then coming to the picture, statins, it's around 25 trials, all are landmark trial, which shows a statistically significant reduction of LDL cholesterol, but some extent of patient could not achieve. That is, we are going to see other thing, bile acid sequestrants and ileal bypass and PCSK9 inhibitors, that is also in the current practice. So the comparison of LDL cholesterol target in ESC 2016 versus 2019, everybody knows the risk category, we make it as a low risk, moderate risk, high risk, and very high risk. In ESC 2016, they target as a targeted LDL cholesterol when patient on low risk, moderate risk and less than 115. High risk less than 100 and very high 70. This is 2016. When come to 2019, when patient on moderate, high risk and very high risk, they are reducing the LDL cholesterol stringently, very strictly by giving this one. Whether we are going to achieve by LDL cholesterol, that is very important. Based on the revised ESG guideline, how many patients do have controlled LDL cholesterol? Definitely the answer is no, we cannot achieve all patients by this recommended level. So this Da Vinci study, which have a lipid modifying therapy used in the secondary and primary care, this is a cross-sectional observational study. Patient prescribed the lipid lowering drugs for primary and secondary prevention, which is conducted around 18 countries, including in the Europe involved, and total number of patients around 6,000. For primary prevention purpose, 3,000, and secondary prevention around 2,900. The objective to evaluate the impact of 2019 dyslipidemia management, where the LDL cholesterol less than 70 for high risk and very high risk for less than 55. So in Da Vinci study, statin usage in all patients, you can see the proportion of patients achieving the goal by giving the drugs like you can see here from low intensity statin monotherapy, moderate intensity statin in the monotherapy, high intensity, and add on estimizumab and PCSK and other lipid lowering drugs. As per revised guideline 2019, 27.6 eligible patients are receiving high intensity statin, and 30% of patients achieved lipid goals with high intensity statin. This is in the trial, where you can see here that high intensity statin around 28 and 30% in the very high intensity patient achieved by using the lipid lowering drugs. Statin usage in very high risk patients, that is also around 37, and eligible patient receiving high intensity statin, and 22% achieved the lipid goal with the high intensity statin. You can see here. So management of patient receiving bemdac acid in the therapy when you are taking other lipid lowering therapy. Some brief point about it. It's a half-life around 21 hours. It's elimination by 70% excretion through the by renal wise, and 5% through the feces, and less than 2% by unchanged form through the renal only. So where the no dose adjustment necessary in renal impairment patient, there is no study for end-stage renal disease. And also in hepatic, there is no concern and not study for hepatic failure patients. So before starting bemdac acid, we have to assess the serum uric acid clinically and prior history of gout. These are very, very important. And more than 60 years of age, taking the corticosteroids, phenyloquinolones, renal failure therapy, these and all warm potential for tendon rupture. I advise the patient to rest first sign of tendinitis or tendon rupture. Where the patient should be discontinued, these and all monitor, where the patient should be discontinued, where more than 60 years of age, taking corticosteroid, phenyloquinolones with renal failure, the history of tendon rupture should be discontinued, and inflammation occur to the patient. Taking simvastatin dose more than 20 or pravastatin 40, avoid concomitant use of bemdac. That is very important. Simvastatin and pravastatin should be avoid the combination. Pregnant, as usual, the discontinue the bemdac acid unless benefits of therapy overweight through the risk. Breastfeeding, no recommended during the breastfeeding time. So finally we come into the clear outcomes. This trial, the cholesterol lowering via bemdac acid in ACL inhibiting regimen, where this clear trial which shows statistically significant improvement when compared with the statins with the placebos. So clear outcomes from ACC guideline 2023, global CVOT study of bemdac acid in statin tolerance patient with the elevated LDL cholesterol, both primary and secondary prevention. Statin intolerant patient they started like this in visit 1 in the 5 weeks, and 4 weeks run-in period treatment with a single blind placebos, and visit 1 they start the bemdac acid 180 mg per day for 7,000 patients and placebos for 7,000 patients. So the study completion around 160 primary with 4 components of MACE and at least for 2 years. The primary endpoint for component of MACE, CV death, that MACE is including CV death, non-fatal MI, non-fatal stroke, and coronary revascularization. In the median follow-up around 40.6 months. So these are outcome demographic data. We are not going much into that. So these are outcomes for primary results. You can see all 4 component of MACE, the primary endpoint, were statistically significant from the placebos, the bemdac acid with the placebos. You can see here is the p-values less than 0.05. So the point MACE, 4-point MACE relative risk reduction 13%, 3-point MACE 15% relative risk reduction, fatal or non-fatal MI around 23% risk reduction. The patient needed revascularization around 19%. These all graphs can show statistically significant after the outcome of clear study. So the background, the patient should be in statin intolerance and starting the bemdac acid, and CV outcomes should be assessed. So occur in 15% of treated patients and prevents the patients from achieving LDL cholesterol level in cardiovascular patients, those who are statin intense. So bemdac acid is we already told about, it's a ATP citrase lyase inhibitor. This is ACL inhibitor, and bemdac acid approved in the lowering LDL cholesterol. The primary and key secondary endpoints are the primary 4 points is like non-fatal MI, non-fatal stroke, and coronary revascularization and cardiovascular death. These 4 years already we saw that with statistically significant improvement compared with the placebo, and hierarchical testing for key secondary endpoint like 3-point MACE, MI, stroke, and CV death, fatal, non-fatal MI, coronary revascularization, and cardiovascular death, and all-cause mortality. All factors are statistically significant improvement. The effect of trial regimen on CV events among statin intolerant patients, treatment with the bemdac acid associated with the lower risk, like as already we discussed, around 4-point MACE 13% reduction, 13% reduction of compared with the placebos, 3-point around 15%, non-fatal MI 23%, coronary revascularization 19%. So LDL cholesterol and hsCRP reduction is statistically significant, and outcome in the safety analysis we already discussed about it. So the conclusion, bemdac acid became a first ACL inhibitor and first oral non-statin to demonstrated statistically significant reduction of MACE 4 events in patients with or who are high risk cardiovascular disease with a documented statin intolerance and elevated LDL cholesterol. So the conclusion, bemdac acid an effective alternative for statin intolerant patient out from the clear trials outcome. It's a well tolerated and LDL and hsCRP reduction is around 21% in the LDL cholesterol and hsCRP around 22%. Small increase in incidence of gout and cholelithiasis. And I already discussed about primary and secondary endpoints. And the effective approach, the bemdac acid an effective approach of reducing major cardiovascular events in the patient statin intolerant group. Thank you. So we can go for.
Thank you so much, sir. It was wonderful to the point presentation, and you covered all the aspects of bempedoic acid clear outcomes trial. There are a few questions online I have. I'm just refreshing the box. So there's one question about what should be the ideal patient profile for bempedoic acid, because we talked about statin intolerance and maximum tolerated dose of statin. So what is the ideal profile for the patients?
So our goal, the primary point, our goal is should be LDL in our recommended one. If patient should not achieve, could not achieve by the statin, high dose statin or intolerant group of patient, even patient those who are in high dose and it's not achieving the LDL cholesterol by our recommended or high dose statin or moderate dose statin intolerance, then we can go for bemdac acid. Point number 1. Second, the patient those who are in the even mild renal failure, moderate renal failure, except end stage renal disease, end stage hepatic, and some patients have a gout like tendinitis. That 3 group of patients can be excluded and other group of patients can be added. These are second inclusion point. Others and all, there is some very minimal limitations only. So once we started with the intolerant group or high dose statin, those who are not improving, then we can add the bemdac acid. This is a main recommendation.
Yes, sir. Thank you, sir. Thank you so much. Sir, as you discussed about initially, European Society of Cardiology 2019 guidelines, there is one question. Many patients have uncontrolled LDL-C as per Da Vinci study, but they don't have any complications. So should I increase the dose of statin or to directly add bempedoic acid or ezetimibe?
But usually all our people are not using the recommended dose of high dose statin. Some non-specific muscle pain, they will reduce into, even after revascularization, reduce into atorvastatin 10 mg, 20 mg. You have to give a full dose of statin, then see the level, how it is achieving within 3 to 6 months. If not achieving, then you can add the bempedoic acid. First point, whether we are achieving through the statin, that's very important.
So this next question is, if we are going LDL cholesterol below 40 milligram per deciliter, then can it lead to neurological complication?
To now, my patients, no one reach less than 55. If it is less than 40, as per up to now, there is no studies like early Parkinson, early loss of memory. That is not proven. That is no studies like that. So I don't think so. Neurological. Sometimes some patients may dryness of skin. They lose the the glitteryness of skin. That may I heard, but that is not also proven. So if it is go beyond 40, less than 40, then what, I don't know which drug you added, whether bempedoic acid, only hydrostatin. If it is hydrostatin only, you can reduce the dose and maintain the at least less than 55. As far as my patient, I didn't achieve any patient less than 55. All are around 70, 80 only.
So there's one question is, how long does it take for bempedoic acid to work? Which statin is best to add with bempedoic acid, like atorvastatin or rosuvastatin?
So still we need a lot of time and experience. Up to now, we are using with, when myself, I am using, if it is 40 patient on long term, then add a bempedoic. If there is no muscular symptoms, anything, I will continue. Or if patient on well controlled with the statin, I will keep it up. And we can appreciate the change within 3 to 4 weeks.
Okay.
But still need a long time to assess, because
Yes.
of no one have even I don't have experience around 20 to 25 patients only. So
Okay.
need
Okay.
time to assess.
Yes. Interestingly, trials you presented, there was 22.2% reduction in LDL cholesterol, which was observed 21.7% reduction in LDL cholesterol after 12 weeks of treatment. There is another question is, in routine practice, how much bempedoic acid is safe to use longer duration? Is it benefited more in diabetes mellitus patients?
Yeah, definitely. You have to add 180 only. There is no change in the drug. And as much as we have to achieve the goal of LDL, up to that you have to continue your treatment. Definitely, it is in diabetes, whoever the risk factor, it is increasing the risk only. So definitely there is add-on benefit when you are even diabetes, hypertensive patient, other comorbid patient. Definitely it will be helpful.
So this is a question from my side. How you define statin intolerance? Means if patient is coming to you, then how you say that patient is having statin intolerance for our healthcare practitioners to understand?
Actually very subjective. Our mind always said, something, patient have some statin, they developed some non-specific small localized muscle pain, they will attribute to it's due to statin. So we
Yes.
have to try to explain to them this is not due to myalgia of statin. Usually statin myalgia is a generalized, not a localized. Some tiredness, some localized pain, those who are taking as a statin intolerance, that is not true. That patient, we have to explain the patient, then give the high dose statin. After sometimes they will ignore it. That is one. But if there is a statin intolerance like myalgia, and those things and all, they have a severe muscle pain, especially those who are in the renal these patients, CKD patients. So definitely they have a severe myalgia, and some patient may land with the rhabdomyolysis also. So that is entirely different. Though
Age is a factor, sir.
yeah, definitely is a factor. I never going beyond 40 mg for 70 or 80-year-old man, only 40. They have a symptoms, definitely. Not of severe myalgia, but they have some myalgic symptoms.
So do you consider these are the ideal patients wherein myalgia and muscle related symptoms you feel after increasing the dose of statin? So we can
go for bempedoic acid.
Bempedoic acid.
Without any contraindications.
Yes. That is one contraindication which can be ignored in bempedoic acid. So there's one question from my side is which one you target more, LDL cholesterol or triglycerides, which is very important for you?
For me, LDL cholesterol is important. So that is a marker.
So everyone is talking about apolipoprotein B, which has to be.
That is still going in depth. So these are clinical practicing people using the LDL cholesterol. So still, if you want to go in depth, you can go for apolipoprotein B, those things. Triglycerides, not much come into the picture.
So if I decrease LDL cholesterol more, definitely apolipoprotein B will go down. Not, it has no any connection with triglycerides.
No,
and that is very important.
It may, for example, if patient have a triglyceridemia, familial triglyceridemia, then you have to concentrate on this. Generalized increased dyslipidemia, no need to bother with those things. For example, the patient on familial triglyceridemia, those who are in thousands in value, then you have to concentrate, definitely give the importance to that. That may be a culprit than LDL cholesterol.
Yes, sir. There's one question. This is the last question from my side. Is about when we are talking about LDL cholesterol management, dyslipidemia management, how HSCRP comes in play is very important. And then
all coronary events starts with inflammation only. If the plaque rupture or around this development of plaque, so in the plaque there is inflammatory activities going to be started. So the inflammatory marker is HSCRP. So once your plaque stability or inside the lipid content, everything is controlled or stabilized by lipid lowering drugs, either statins or bempedoic acid. So inflammation also will coming down. So HSCRP also will be coming down. So that is a one marker which is reducing by statins by acting on the plaque stability.
Yes, sir. So that was a good point that statins were earlier associated with lesser HSCRP reduction, with greater HSCRP reduction. Now bempedoic acid is another choice we have got when there is HSCRP reduction which has been seen. And on a positive note, would like to have your final concluding remarks for today's CLEARTalk.
Yeah, the patient, our aim to achieve LDL cholesterol, those who are especially those who are in the coronary high risk patients. So you have to achieve the LDL cholesterol at the recommended. For example, if patient on high risk reduce into around less than 55 and high risk 70. So if you are not achieving by high statin cholesterol, high statins, then you have to add on the bempedoic acid. If not intolerant. If intolerant, you can directly go for bempedoic acid by our aim to reduce the LDL cholesterol. Thank you.
Thank you so much, sir. It was indeed a pleasure having you on this evening talking about Clear Outcomes trial. So the knowledge which you have imparted to our all delegates will definitely help them in day-to-day practice. And I'm really thankful for you for your presence, giving us time. I would like to thank from Zydus Life Sciences point of view to all our delegates who have joined and asking questions so that this platform is more interactive rather than one-way trafficking. And thank you so much, all the delegates, and wishing you a happy evening. Again, thanks a lot, sir. Thanks a lot for joining us.
Thank you very much for side testing.